Oh my goodness. There we go. Okay, so we're opening up the floor to invite our participants to come in and join us now. That's great. Just so we can see you all have access. There we go. I'm making a lot of noise. Perfect. Okay, people are starting to come in. I'm going to just start in the chat box. I don't believe it, but my phone is not. There we go. I'm just going to shut my phone off because I don't know what just happened. Okay, in our chat box, I'm going to write hello from. And if you want to make sure you're sending the message to everyone, we'd love to hear where you're watching from tonight, just so we get an idea of geography here and where you are. Wow, Sudbury, Kingston. This sort of reinforces how valuable these webinars are, aren't they? Like you would not have traveled from Sudbury to find this. So we're so grateful we can send this information virtually. Well, hello, Samantha. That's lovely. Wheatley, Trenton. My goodness, Terrace Bay. Is Terrace Bay out east? Where is Terrace Bay? Now I need to know. Illinois. Look at that. We are international, folks.
And I see somebody from Wheatley. I'm originally from Leamington, so I know where Wheatley is.
There you go. Never would I have known. Well done.
Nice little place.
We're just going to take a few minutes. We'll probably start a couple minutes after 7. So. While we're starting to, I'm going to pop up just a quick poll. And by quick poll, it is 2 questions. So there you go. We're going to find out, how's your research knowledge? Where would you rate yourself? So how would you rate your research knowledge, your comfort level from 1 to 5? So you're going to pick a single choice. Does that work? There we go. They're coming in. And are you considering taking the Demystifying Research course offered by RPN? Cool. We want to thank you as well for attending so late in the evening with your busy schedules. And we're hoping this is a nice, quiet presentation where you can sort of sit and absorb and not work quite so hard. I'm loving the little conversations in the chat. Help yourself in there. Introduce yourself to others. Okay, now we've learned tonight that Terrace Bay is near Thunder Bay. Sorry, I keep putting it on mute. 7:01, we'll give you 2 more minutes and then we're going to get started. I see we don't have any expert level researchers here with us yet, so there's still some space for them. Okay, I'm going to end our little poll. I'm going to share the results. So it looks like we have some level 1s, level 2s, and a lot that are in the level 3, feeling pretty confident. And some that are interested in finding out more about our courses. So there you go. Okay, I think we're going to get started. So I'm off mute. Perfect. We're all set to go, everyone? Yeah. Okay, so good evening to all of you. Welcome to RPN's quarterly research webinar. I'll start by advising you this presentation is being recorded and to remind you to please take a moment and ensure you've turned off your mics. To keep the flow of the evening, we ask that you hold your questions to the end of the presentation and we'll address them all then. We'll give you time to ask questions for anybody on the panel at the end. So without further ado, I'll introduce Suzanne Schell, RPN, who is currently the president of the board of directors for WeRPN. Suzanne works in ambulatory care hospital and teaches in the practical nursing program at St. Lawrence College. So Suzanne, let's get started.
Hi, everyone, and good evening and welcome. My name is Suzanne Schell, and yes, I am the president of the board of directors for WeRPN. I am very pleased that you could all join us tonight as we offer the first of WeRPN's new quarterly webinar series on research. For many years, WeRPN recognized there was an abundance of nursing research that examined students and nurses' experiences from their education to practice in a variety. However, there was little inclusion of RPNs or research specifically focused on the experiences of RPNs. Several years ago, WeRPN conducted focus groups and interviews with RPNs and other stakeholders, and from this information developed a research strategy. As part of our strategy, WeRPN introduced a research advisory council to oversee our research activities, and one of the goals was to create more opportunities for researchers to study the experiences of RPNs. This year, the Research Advisory Council approved funding for 4 studies in Ontario. They are currently being conducted by researchers at Western University, Unity Health, Conestoga College, and BHA. RPNs also told us that they would like to participate in research, and a second goal of our strategy was to provide more opportunities by creating research fellowships. This year, we funded 2 RPN research fellowships and they are currently underway with RPNs participating as members of the Western University and Unity Health's research teams. We also developed a process for researchers to access RPN participation in research studies. And we are so pleased that this process has allowed researchers like Dr. Peter to study the experiences of RPNs. So with that, I would like to introduce our esteemed presenter this evening, Dr. Elizabeth Peter. Dr. Elizabeth Peter is a professor at the Bloomberg Faculty of Nursing and a member of the Joint Center for Bioethics at the University of Toronto, Canada. She is an associate editor of Nursing Ethics, the vice chair of the Bioethics Expert Panel for the American Academy of Nursing, and the chair of Public Health Ontario's Ethics Review Board. Her interdisciplinary academic background in nursing, philosophy, and bioethics has framed her scholarship for over the past 30 years. She is currently funded by Toronto's COVID-19 Action Initiative grant to examine the moral concerns of nurses during the pandemic. Welcome, Dr. Peter.
Oh, thank you so much for that invitation. And thank you so much for helping me with the recruitment, helping the whole team for this project, what I'll describe later, because you've been absolutely instrumental. And I'm going to introduce our co-presenter, who's Dawn Rose, who you can see at the bottom of the screen. Dawn is an associate professor and former director of the Daphne Cockwell School of Nursing at Ryerson University. Dawn began his nursing career as an RPN, where he worked in a long-term care home for 4 years. As he advanced his nursing education, he held several positions in clinical practice, administration, education in Canada and the US. Dawn's teaching in undergraduate and graduate nursing is focused on nursing ethics, leadership, and clinical practice. His research foci includes nursing ethics, mental health nursing, and nursing education. He has also been involved in Sigma Theta Tau at the chapter, region, and organization levels. So thank you for Dawn for joining me. He's a huge part of this research. Dawn and I have known each other forever. So it's really great through many different parts of our lives that we cross paths. And this time it's with doing this project. So he's instrumental to this, and he'll be presenting in the middle and I'll be presenting at the beginning and the end. Okay. So the study name is RPNs Experiences of the Moral Habitability of long-term care environments during the COVID-19 pandemic. And I'll be describing moral habitability. It's a technical term for something that's relatively straightforward. And so we've been looking at the RPNs experiences, and these are the preliminary results of our study. There are other people involved in this team, including Sean Mohammed, he's also from U of T, Priscilla Boache from Ryerson, Tegan Kalaki, who's now at SickKids doing a postdoc, and Jane McIver, who's also at the Faculty of Nursing at the University of Toronto. As mentioned, this study was funded by the Toronto COVID-19 Action Initiative, and we're grateful to that funding. And especially a big thank you to our participants, who obviously without their incredible insights, we wouldn't be able to conduct this research at all. So as a little bit of a background, and I think that most of you are quite aware that there have been concerns about quality of care in long-term care in Canada for quite a long time. There have been many reports, in fact, more than 100 in the last 50 years, but not much ever really changes, despite the fact that there's a great deal actually of high quality of research that could be helpful to the long-term care sector. The other thing that's obviously clear to you is that there have been a very high number of resident deaths during the pandemic, especially in wave 1 and wave 2. And we know that the end-of-life care for these residents has often been inadequate. They've often been left to die alone or without their fundamental needs met. So for some technical information here, we know that in wave 1, so this is beginning in 2020, We know that 79% of the deaths in Canada were in long-term care, which is incredibly huge. I mean, it's tragic. In wave 2, things came down a bit. There were 60% of the deaths occurred in long-term care, but that's still high. And you'll also notice that a lot of staff became ill, and there were some deaths. By the end of the second wave, there had been 28 deaths in long-term care of staff. On the weekend, I looked to see that the latest information. So this is accurate up to February 2nd of this year. So there have been a lot of resident deaths. It's good to see that the percentage of deaths has gone down to 48%. I mean, no doubt that has to do with vaccinations and also putting into place perhaps some better public health measures. But the number of staff cases has also been extraordinarily high, with 32 deaths of people working in long-term care as a result of COVID. So that's a bit of a background. The other thing that we know about long-term care is that over the years, there's been a real reduction in regulated staff. Most of the care, about 90%, is provided by unregulated staff. And a lot of the care also that doesn't really figure into some of these statistics is how much care family members are also often providing. This workforce, many of them women, many immigrants, they tend not to have a lot of voice and power in the system. They may be highly educated in some ways, or they may be very limited in education in terms of their nursing background. So this typically, of course, would be a PSW. And their wages have been low, although they have increased somewhat recently. And long-term care homes in Ontario have another interesting background and breakdown. And a lot of media attention has been paid to this as well. I mean, we know that 16% are publicly owned. And in these homes, there have been lower deaths and lower problems, if you will. But that 57% that are owned privately and for profit has been where some of the most significant difficulties have been, largely as a result of a lack of staffing and the problems that this has created. There's also a smaller chunk that are private, but not for profit. And throughout this, I think we're going to be emphasizing that the difficulties that nurses have encountered are not their fault. I mean, they're a result of the structures and, particularly these for-profit organizations who've made it impossible for nurses to provide the care they would like to provide. So what has the impact had on the pandemic on workers who work in long-term care, nurses and others? Well, we know in Canada and internationally that there's high workload and lack of staff. I mean, this existed pre-pandemic, but it was made worse by the pandemic because of the added workload, because of staff members getting sick, because of family being pulled out. So the workload has been extraordinarily high. Many have complained about the lack of organizational support. That's been an almost consistent theme. And frankly, when it comes to the long-term care workforce, what we see in the research is really some very extreme findings of emotional exhaustion and stress. Nurses in these environments and other workers have been exposed to an enormous amount of death. They've been exhausted, they've worked extra hours. They've been, especially early in the pandemic, very afraid of becoming sick and making their family members sick as well. I mean, some of that certainly continues. Some of it has been lessened by vaccines and other measures, but that fear of contagion is still there and is, of course, realistic. It's a legitimate concern to have. So a little bit of theory, and I'm going to explain moral habitability. In the research world of ethics, it's normally necessary to really have a concept or concepts to structure research, because ethics is such a slippery word. We use it in so many different ways. We use it in research, we use it in our everyday language and so on. So typically we find a way of conceptualizing this so we can really put some boundaries around what we're doing in research. So moral habitability really refers to a type of environment, or a morally habitable environment is where people have responsibilities. And an environment could be a long-term care environment. You could choose other environments, but we looked specifically at long-term care. But in an environment like that, members of the group cooperate with each other. And they also share things. So people share benefits, if you will. They all share, let's say, in getting a reasonable wage. They share in receiving any kind of praise, if you will, or any kind of benefits that's there, and recognition is shared. So there's mutual recognition, as opposed to some people being recognized as opposed to others. Members of this group understand each other in terms of who's responsible for what, and they hold themselves accountable, and they hold other people accountable as well. So this is really idealistic. So this is the ideal, morally habitable environment. Probably none of us have ever been in such a perfect environment, but somewhere on the scale, that's ideal. As opposed to the other extreme, where we have environments where people suffer, and they suffer because their responsibilities aren't clear. There is a lack of accountability by some members. Perhaps there's oppression. Some group members are too powerful, others not powerful enough. Sometimes the responsibilities people are given just don't make sense. And so there's this lack of clarity, there's a lack of cooperation, and there's this lack of mutual recognition. So we use this concept, recognizing that there's a whole continuum of really great, really awful, and everything in between. Okay, so specifically, the purpose of our research, and as any research problem, you write down something that's very specific. Ours was to explore RPNs experiences of the moral habitability of long-term care environments in Ontario during the COVID-19 pandemic. And we very deliberately chose RPNs because RPNs have an enormous responsibility in long-term care. They're leaders in long-term care. They know the residents. And we also were wondering what kind of burden was placed on RPNs during the pandemic and continuing. So we really recognized the core of the workforce and the leadership of that workforce resting largely on RPNs. So this is why we chose to focus on RPNs. Okay, so as our methodology, we use something called critical qualitative. So this is a qualitative approach. And in this kind of approach, it includes a need for everyone to be very self-aware in terms of interviewing participants, conducting data analysis, and so forth. Like all research, we received ethics approval and also informed consent. And like I was mentioning in the beginning, WeRPN has been instrumental. They're the ones, or you've been the ones, who've used your newsletter, Twitter, Facebook, and LinkedIn to get us participants. That was wonderful. And a little bit of word of mouth. We had a little bit of participants talking to perhaps their fellow RPN friends and so on. So we had a little bit of word of mouth as well, but mainly came through WeRPN. We used interviews to conduct our data, and we did them over Microsoft Teams because of the pandemic. The plus of that, however, is the same plus as this webinar, is that we could reach across the province. It didn't have to be people in Toronto, which was great. And we are actually still somewhat in the process of data analysis, where we're looking at all those transcripts, looking for patterns, looking for meanings and shared understandings, and then bringing some theory to bear on our understandings. So we're getting close to the end of data analysis, but the team has been meeting regularly just to sharpen up what we've been doing. Okay, so ultimately we had 20 RPNs. They were all from Ontario, and we were really, really pleased that 16 came from outside the GTA, because this gave us a nice range of Ontario. So we were really happy about that. Experience, half of them had 5 years or less, but the average was 8.15 years. And the type of home was pretty much like the types of homes that exist in the province. Some publicly owned, some private for profit, and some private not for profit. And there was also one home care nurse working in long-term care who was a little bit different, but we had a nice range of different kinds of institutions. So our findings, which I'm going to turn over to Don.
Great, thank you, Elizabeth. So as Elizabeth said, we're going to be presenting our preliminary findings really this evening. We hope at this point we are getting close, as there have been 4 researchers that have been particularly involved in this data analysis segment of the research. So we're happy to share these findings with you this evening. So in the coming slides, there will be a number of quotes that we will be sharing with you. I'm not going to read through the quotes, but I'm going to try to speak to them so that you can get a gist of what some of the participants offered in the interviews that we conducted with them. So next slide, Elizabeth. So the first theme that we have articulated at this point is striving to meet responsibilities in a failed system. And Elizabeth, if you can go to the next slide. Participants spoke largely on a focus primarily, pardon me, about the government. There was a huge awareness, even pre-pandemic, as Elizabeth has already said, in the context of the situation that long-term care was in Ontario. And then certainly since the pandemic, it really just magnified what was happening in long-term care, and certainly with RPNs. And our participants spoke very much about private versus public and the differences between the two in nursing homes, and also spoke about the resources. So the lack of human resources, the lack of supplies, as well as fiscal resources. So participants often spoke to having to work short, staff calling in sick, not being replaced, having to work extra overtime, and things like that. So there was a sense really of holding government accountable and hoping that as a result of what happened during the pandemic, that now they can actually enact some change as a result of what has come to the fore, if you will. Next slide, Elizabeth. There was also, so this slide speaks to the sick time or people going off sick and not being replaced. Staff often felt that they were also abandoned by the system. So Elizabeth, you can go to the next slide. So participants felt very much that they were abandoned by the system. Again, when they spoke of the system, they spoke of government, but also participants also talked about the organization being abandoned by the organization. They often refer to management having abandoned them, and also being abandoned at the unit level as well by their respective managers, as well as sometimes their colleagues. And in all of this, there was a real desire for a need for change and a change at those various systems. Elizabeth, can you go to the next slide? And the other piece that participants spoke to was that they felt that their moral standards were violated. They felt that things like their honesty, that they were lied to, that they were lied about accountability, and that they were lied about a number of things in their working environments. Next slide, Elizabeth. So really, before I get into this theme, some of the impact of that striving to meet responsibilities in a failed system, participants really described this notion of experiencing moral distress. And they also described that they weren't able to meet the standards of care, and for numerous reasons. So for one thing, pardon me, just pull up my notes. One concern that staff had was around the notion of skeleton staffing and not being having staffing replaced, or oftentimes they felt that the absence of family members was also interfering with them to be able to meet the standards of care, and certainly that highlighted how significant family members were in providing care for residents as well. They also spoke to having to leave things undone. They described their care as being very task-oriented, and that there was overall a lack of time to provide care. So it was really challenging to cope under those circumstances. So the next theme that we have is the theme of knowing the realities of the work, yet failing to be heard or recognized or supported. And so participants spoke about, so if you go to the next slide, Elizabeth. One of the things that the participants really articulated was that they recognized the need of care for the elderly in long-term care, and they really did a great job in highlighting that. But they spoke to the fact that they were also aware of how the staffing shortages and prior to pandemic and during pandemic were problematic, but yet their voices were not heard. Next slide, Elizabeth. Participants also spoke to the fact that they felt that they weren't recognized, and used the language of feeling devalued in the system as well. And one of the examples that participants spoke about was when the PSWs received a $3 hourly wage increase, and the RPNs felt that that created an equal pay grade, which to them felt demoralizing and unfair, and rightfully so. But the participants also said, like, they didn't even hear from their employers, have recognition from their employers that this was problematic and unfair. And they said, all we really wanted to hear was that there was some recognition of this and that the unfair practice that is going on. Next slide, Elizabeth. So the quote on this slide is another example of certainly not being listened to and not being recognized by colleagues and even management. And the second quote highlights the fact that staff workload expectations of participants and the exhaustion that they were experiencing from working during the pandemic. Next slide, Elizabeth. So the third theme we've titled as bearing the moral weight of proximity to residents and their families. Next slide, Elizabeth. So this quote here speaks to the participants' perception of being exploited. They spoke to feeling that there was an abuse of power between management and the RPNs. And this particular participant was quoted as saying that she felt like, I'm just a slave. And so again, this is really problematic when you think about working in those conditions, and particularly the conditions of the pandemic as well. Next slide, Elizabeth. So the two quotes on this slide really highlight how participants really come to know the residents in depth, and speaks to the kind of relationships that they have with residents as well as family members. And it really speaks to, I think, a unique and wonderful experience of being able to have therapeutic relationships with residents in the depth that the RPN spoke of, but that became problematic in the pandemic because they weren't able to maintain and sustain those relationships that they do have. So in some ways, it's kind of a unique feature that occurs in long-term care when the conditions are right. And certainly with the pandemic, the conditions were not right for them to be able to continue those relationships. And it also spoke to the close proximity that they had with the residents, and not only residents, with the residents' family, their grandchildren. Participants spoke about the numerous family members that they also had relationships with during the care that residents received. Next slide, Elizabeth. So the fourth theme was agonizing and making do with the frequency and inadequacy of end-of-life care. We had a lot of data on this particular theme. And so if you go to the next slide, Elizabeth. So this quote really captures the participants' experience of watching a resident die alone and not having the ability to be with the residents. This was a real sense of distress and disconnect that staff were feeling with residents dying. One of the participants told a story of working short, and there was a resident who was dying. Family weren't able to come into the building at that point in time. And she really didn't want the resident to be alone and was struggling with the fact that she would have to leave the resident alone. But what she did was when she was in the room with the resident, she noticed there was a family photo on the dresser. And she took the family photo and tucked it in the woman's arms. And so the woman could hold it. And she said that was the only way that she could know that the woman wasn't alone and that her family could be with her some way. So it was quite touching with some of the responses that we heard. The next slide, Elizabeth. This is a lot of content here, but the gist of it is, again, how participants discussed and described the inadequacy of end-of-life care during COVID, and particularly as COVID progressed and with the lockdowns. They talked a lot about the changes in post-mortem care during COVID. So initially pre-pandemic, and I think at the beginning of the pandemic, the funeral staff would arrive and would take care of the body, put it in the bag, and remove it from the home. But in this particular wave of COVID, that stopped. And staff would have to go meet the funeral staff at the door of the facility, take the funeral home equipment, the gurney and body bag, and they would have to then do that work that was typically done by the funeral staff. And they found this particularly challenging because, again, of the relationships that they had with the residents. So it was problematic and distressing for them as well. The next slide, Elizabeth. So this participant really spoke to, the emotional impact that dying was having on RPNs and the witnessing of the residents dying. And again, because of the relationships that they have with the residents, as well as the relationships that they have with the family members as well. Next slide, please, Elizabeth. So our final theme was coping with exhaustion and making transparent the need for change. Next slide. So on this slide, the participants have identified the need to have collegial support when coping. And this particular participant talked about just simple, your day-to-day interactions and being able to joke and have some fun and some laughs with your colleagues. And that this interaction with colleagues also provided them with an opportunity to create some strategies and solutions to what they were experiencing day in and day out. And so they spoke to how important for their coping, the relationships with their colleagues were. Next slide, Elizabeth. These two quotes speak to the participants' experience again of distress. One of the participants spoke to feeling tormented, and that going to work was pure agony for this particular participant. So again, it really speaks to that notion of distress and the impact that that can have on your ability to function, if you will, in your work environment. Next slide. And these two participant quotes are using quitting as a coping mechanism, and they're speaking to either knowing that they're going to quit or that they have quit, and that they really feel that in long-term care that the pay and just the volume of work that is expected, that no one is going to want to do it. And then next slide, Elizabeth. So this quote was taken from a participant who was expressing their gratitude to be able to participate in the study, and that there was a sense of hope that even through this research, that this could also be a catalyst for positive change in the system. And so it really speaks to participants finding their own voice through participating in this research. And Elizabeth, I think that's it for me. Over to you. Thank you.
Well, thanks, Don. Okay, some conclusions and implications. I mean, and no doubt these interviews that we conducted were really heavy, and so are the results. I mean, there were a few bright spots, but for the most part, it was very difficult for RPNs. So it was very easy to answer the research question, if you will, in the sense that RPNs experienced long-term care environments during the pandemic as morally uninhabitable. I mean, I think that was really easy to answer. A lot of them experienced a lot of suffering. They were unheard, but had so much to say. They were doing things that sometimes didn't make sense, especially with end-of-life care. It was inconsistent with the kind of care they wanted to give. Especially in the beginning, there was that lack of government and institutional accountability. There were a couple participants who did talk about a supportive institution, but they were the exception for sure. And participants also talked about what we call the moral community with their colleagues. So a lot of them really found and spoke about their colleagues as being what allowed them, if you will, to continue to go back to work. And that sometimes people at home don't quite get it, but that their colleagues were incredibly important. So Dawn talked a little bit about proximity, which I'm going to expand on a little bit in terms of our moral responsibilities. So proximity is something, or being close, is something that can be defined in all kinds of ways. And we can be close to people in a relationship, like friends and family, residents in long-term care. And we can be close also spatially and temporally. So we can be at the bedside, if you will. So that also is proximity. And what we know about proximity in humans is that with most of us, not everyone, most of us become morally sensitized when we're close, when we're either physically close, emotionally close to people. It tends to foster compassion, but along with that compassion can also come distress from being so close to someone else's suffering. So for the most part, it's a really important way that humans are wired, that we care deeply about people close to us, but it can be too much because generally speaking, it really compels us. We normally jump and take responsibility when we're close. Even if we're passersby and see someone in distress on the sidewalk, typically people will intervene and help. So in terms of RPNs, I think the situation, what happened is you have a group of dedicated professionals who are close to the residents, and they're the ones left standing, if you will. So they continued to go into work despite the conditions. And some of them really explicitly talked about being exploited in a sense, because in some ways, you can think of the entire public is dependent on people who will stay in place, who will continue to be responsible. The downside of that, however, is the acute distress that went along with it. The suffering of the death of residents and so on. I mean, it's one thing to watch something on television. It's one thing to be conducting research, but to be there physically present is where the suffering is the greatest. And we found a lot of our participants also felt really guilty. They felt really bad and held themselves to be morally accountable for things, even though the circumstances under which they were practicing made ideal care less than possible. The nice part of the proximity, however, was their colleagues, the colleagues that were close by, the ones they had close relationships with. That was a plus of proximity. And also, if we think about our work responsibilities, what do our work environments obviously have a huge impact on those so-called moral responsibilities? And all of us went to school. Most of us had some pretty high moral ideals taught to us, if you will, in our practice. If you look at codes of ethics, like this one from the ICN, they talk about nurses being responsible to promote health, prevent illness, restore health, and alleviate suffering, and to promote a dignified death. I mean, that's normally the ideals in which we all go into practice with. The college sets similar standards about how we're to be accountable and set these high ethical responsibilities. But what happens when we're working under really horrible circumstances? What happens to those ideals, and what's reasonable for nurses to do in those situations? So, I mean, the average nurse going into a situation would really try to live up to the ideals. It would just be, a source of suffering, because it was really completely unattainable in some of the circumstances that our participants described. I mean, they were truly doing their best, but the circumstances made it impossible. I was very pleased when I went on the College of Nurses website, however, that they gave a bit of an update and something to think about during the pandemic. And I hope they're being honest with us, because, the college can be pretty tough. But what they tell us is that we need to understand standards of care in context. So there's one thing to live out an ethical ideal with excellent staffing and no pandemic or whatever, but the standard needs to change. And I think that the college recognizes this. In the pandemic, especially human resources have been really scarce or absent. That has probably been the biggest scarcity in a country like Canada. The CNO also reassures us that even though they'll allow for complaints, that they'll look at the circumstances. And again, the last few times I did a check on who was being disciplined, I didn't see anything that would suggest that nurses were being disciplined about really horrendous circumstances with respect to the pandemic. So let's hope the college really will be supportive. They have a different mandate, of course. They're here to protect the public. So given all this gloom, and I hate to present just gloom, but there actually are some really good recommendations. And I'm not going to summarize them all. There have been so many commissions and reports. They have been excellent. We've had a provincial report. We've had a national report from COVID. We've had, great editorials written with some really solid recommendations to change the entire system that would help residents and would help, obviously, the nurses who provide care for those residents. So there's lots of super suggestions out there. It's a matter of people acting on them. We know that there's also something called the Fixing Long-Term Care Act that may be passed at some point in the future. And here again, you see places where the minimum hours for resident care are specified, which is all the things that in turn allow nurses to practice ethically and for them to, frankly, maintain their sanity. In closing, I think also from some of the work that Dawn and I do, I think one of the things that we always recognize is that nurses, we provide care for other people, but nurses need to be cared for themselves. And in all of this, there's a real, I think, need for recognitions of RPNs by the public and by RPNs themselves about their own relative power. The importance they play in the lives and their long-term care anyway of residents. We found that they were really outspoken and had some really smart things to say about the system. Again, I've talked about setting those moral ideals in some kind of perspective so that there's a freedom from blame, either self-blame or people blaming others. And long term, of course, we have to worry about the health of the entire workforce. And part of that, from our perspective, is also having that opportunity to rebuild moral identity, to again sort of feel like and experience oneself as being a good nurse. For some of those nurses we spoke to who were really, really crushed and were really feeling terrible, even though they for sure did the best that they could, but we're still feeling like they were to blame. So that's our presentation, and we be very open to your comments or your questions. They'd be great to hear.
Wonderful. Like, I want to applaud and I want to cry as well. So thank you both for bringing these results to light, for giving us just a small glimpse into what RPNs have been going through and continue to go through. I'm sure everybody listening today can relate to some and or all of what was brought to light. So this research will help us better support and respond to our RPNs. So now we'd like to open the webinar up to any questions you may have. So feel free to raise your hand, enter your questions or thoughts into the chat. I know this is the part where everybody gets very shy and doesn't want to come forward. But by all means, this is a nice quiet spot. If you had any comments, if you related to anything there, if you had any questions as to what happens going forward, please jump in. Suzanne and Nancy, if you had any specific questions you might want to ask. I will say it's nice to see all those that started with us are still with us. So thank you. Thank you for hanging out with us this evening.
I had a question. So you mentioned that the moral habitability existed before. How do we actually measure it, or how do you? I mean, we can describe it, but is there opportunity to measure it so that homes can see themselves improved if they really worked on it? I think WeRPN has talked about trying to use the concepts of joy and work as a way of improving the environment. I mean, this was a very difficult time and continues to be. But if we were ever going to ease out of it or get out of it, what would be some ways we could measure this and work on it without being in crisis?
Yeah. Well, I can take a stab on the measuring it. I mean, there would be ways of turning this into a, a measurement or a tool that nurses could fill out. It's not within my skill set, but there are people who are, whose expertise is in scale development. So it's possible that this could turn into something like that you could check off and quantify. Yeah, that could be a possibility for sure. Be an interesting scale.
And I think, Elizabeth, if you think about the items that we already have, right, around, the oppression, the suffering, I mean, there's already other scales that you could almost borrow from to create a scale, I think, Nancy, to actually measure quantitatively.
Yeah, we almost have to get the dough into systems that matter in terms of like something like part of the accreditation process, or where when they've talked about adding this quadrant to the quadruple aim and staff well-being is a large part of that fourth quadrant. Yet there's still a lot of hesitancy to accept that fourth quadrant and put it in systems or methods to make people take it seriously. I mean, RPNs and other healthcare staff are our most important asset, really, when we're coming down to care, especially in long-term care. So.
Oh yeah, and if you think about how much money is spent on educating nurses, recruiting nurses, why not put some effort into retaining them? So.
Yeah, and it's going to take a lot of effort. There's so much trauma.
And Elizabeth, to your point, I mean, we do focus a lot on focusing on nurses who are exiting rather than putting the effort in up front and trying to spend time to see what it's going to take to retain you in the system and what can we do as an organization as well as a system to keep you.
Okay, I'm going to jump in. We have Suzanne has a question. Suzanne, you want to go ahead?
Yeah, I have a few notes here, so I'm just going to read them off. We hear from students that long-term care sector is not really seen as their choice practice area. And given the struggles that you currently have identified, what do we need to do as a society to change all these perceptions about long-term care, to bring more people into this area? What can we do?
Wow, I mean, I'll do my best. I mean, I think, nurses, for the most part, we don't know, the public doesn't know enough about what nurses do. Because I think that, nurses talking about their work in long-term care, not so much during the pandemic, but their importance and the joy they also experience on an everyday level, working with residents and so on. I mean, for instance, my parents live in like an assisted living, and there's an RPN who does, runs all the health things. And it's now that I'm dependent on a nurse that I 10 times more appreciate nurses, like on an emotional level. And I feel like saying, look at, this is what she does. This is amazing. I mean, I've talked to her twice a week, usually email her or whatever. And I wonder, again, intellectually, I've always known the importance of nurses, but now that I'm dependent, because my parents are dependent, I wish people could see the nature of that work and how she knows the residents and how she connects to the families and she organizes things and you see her in the hall, and it's, I'm sure that's rewarding. And I always make a point of saying thank you, because that's something that I think everybody in their work deserves to hear, especially thank you for, like, nobody's died there of COVID, not yet, thank God. And so I routinely, and they're completely neurotic about everybody who comes in. And it's like, thank you for that. But I don't think the average person in the public has any idea, or future nurses, that there's a lot of reward in that work too. You're like holding everybody together. I mean, my parents adore her. So do I. I think she's amazing.
I agree with you, and I tell students that as well. It's a wonderful
Yeah.
experience, and
Yeah.
and anyone I know who may have left often misses it because they
Mhm.
miss that closeness, that connection they have with the residents and the work that they do. Thank you.
Yeah.
Okay, do we have any, see, it's a very quiet bunch now. They're ending their very long days. One question from Lauren is, how many of the participants are at the same facilities as they were in at the first two waves? I guess the question is, did you see people move from place to place?
Well, you know, the only way we could maybe do that is to get on, you know, find a nurse and to see where they are. That would be an interesting question, to just look them up, see where they went. Are they where they were when we interviewed them? Because it's been a few years, not a few years, it's been a few months since we've interviewed them. Yeah, I'd be interested to see how many have moved on. I know one of them had already moved on, and she was doing vaccinations. But the rest of them, that's fascinating. That might be worthwhile looking into because it's public information.
Right. Yeah. Yeah. She's addressing that turnover that she's saying has been huge. So yes. And the fact that agencies are popular.
Yes. Are they ever?
I mean, they're filling a need, but at what cost?
Yeah.
So
I know, exactly.
Yeah.
Changing the landscape drastically, isn't it? So yes, and the money is better. That's part
and the agencies make a whole lot of that money.
Yeah, that's right.
That's right. All right. Well, I think our questions are quiet.
I think there's one more question there. I think there's one from Courtney Young. What are the ways to rebuild moral support for RPNs? What things can be done at the management level to change the culture?
Dawn, you want to try that?
That's a very good question. And I think, you know, if we speak to the voices of our participants, it's the need for recognition, for value, the need for support at the unit level, the organization level, the system level. All of those things, I think, are really important to address that and to start to rebuild. Elizabeth, do you have any thoughts?
The only other thing I would add is that sometimes managers get too far away from the work. So I think sometimes it would help just go to work, put on your scrubs and work alongside the staff and see what the everyday is, see what's really happening, because, and I've worked as a manager before, it's really easy to distance yourself and not get into the weeds. And, you know, going back and being close to the work, the nurses, the residents, and so on, because otherwise you can just become oblivious.
Yeah.
So
part of that might be self-preservation right now too, isn't
exactly.
it? My goodness. Another question from Monique is there any solutions or advice to these issues that have been acknowledged? So I guess, has there been anything positive implemented, or are we hearing anything that's any advice we can give at this point, or are you still compiling data to come up with results for us, or?
Well, I mean, I think that the real solutions are more systemic. So some of the legal changes, maybe better regulations around long-term care will help with the work environments and so on. I mean, that's at the core of the problems. It's just that the RPNs kind of are holding up the whole system and are holding the problems because they're right there with the residents. So those, I think there's more awareness. I think there's more awareness when I watch the news and whatever and hear people speak. But I hope, you know, if this pandemic ends, and please let it end, that that won't be forgotten.
I have to say, when you say just that line where you just said, and RPNs are holding up the whole system, that
Yeah.
just made me very proud. So it does feel that we're the ones with our hands on patients. You know, we're standing
Yeah.
at the front lines.
Yep.
So and I certainly not appropriately acknowledged for that. So yeah, the rules around staffing haven't changed. There's so many things that need to change with this. So this, I think that's, do you see any more questions? Are we down to the end now?
Yeah, I think so.
I think. Okay, Nancy, did you have any finishing
Yeah,
thoughts?
I do.
Okay.
Good evening, everyone. I'm Nancy Snoblin. I'm the research consultant for WeRPN, and on behalf of WeRPN, I'd like to thank Dr. Peter and Dr. Rose for presenting this very thought-provoking discussion this evening. Heart-wrenching, really. I'm sure many of you can really relate to the findings that they had and the concerns expressed by the participants in this study, even as you continue to work through the pandemic. As I said, it's heart-wrenching, yet it's inspiring too that registered practical nurses in long-term care who have such close relationships with their residents can endure such distress and still find ways to adapt and maintain the best quality of care for their residents and families, because they had to be both as they were inside. And even maintain their own well-being during these dire circumstances. I mean, it was literally like really nasty juggling. So thank you both for conducting the important research and for focusing on RPNs and presenting it in such a pragmatic themes that resonate with all of us. We learned a great deal, and we hope RPNs feel heard because that's part of why we're really trying to increase the literature about RPNs so that people have a better knowledge of what they do and what they can bring. So also thank you to Suzanne for stepping in for Annette and to provide the background about our new research strategy, and to Sharon for in the professional practice department for helping run this whole webinar thing and making the quarterly research webinar possible. Sharon, I'll be posting a link to this presentation on the WeRPN website within the next day or two, should you wish to review it. And also, please spread the word about this important evidence and share the link with any colleagues you wish to view it. And now, before we go, as you recall, while you're waiting, we did the poll, and we asked whether you, what level of expertise would you have in terms of research. So we hope that this is a start, you moving from level 1 to level 2, or level 2 to level 3, or level 3 and even to level 4 and 5. And we asked you whether you considered taking the online course Demystifying Research. It's an introductory course on nursing research, and it's offered by WeRPN. It was designed specifically. So the results of 0% had heard about it, so that's good that we're going to tell you about it tonight. I'd like to direct you to the website. It's on there to be learning a little more about it. But for those of you who would like to know more tonight, I'm going to say that it was a course designed by Ben Hartung. He's a practical nursing instructor at Bow Valley College in Calgary right now. But he was previously with St. Elizabeth Healthcare and Baycrest Hospital. And if you ever had a chance to hear Ben speak, you'll know that he's a great teacher and he's really experienced with the work of RPNs. The content is designed to provide RPNs the essential introductory knowledge to use, engage in, and report on research projects. So even a little quality improvement projects you might have at your employment, he's going to talk to you about how you can really work those through in terms of process and even to publication. It's an 8-week asynchronous e-learning, similar to the other WeRPN courses that we offer, where you work at your own pace and facilitated by professional practice. So please consider taking this interactive course so that we can enhance the RPN culture specific for research. On another note, please don't forget to provide us feedback about this evening's presentation on the survey you'll receive from Sharon. It'll come out, I forget what the email comes out as, but it comes out as a survey. We take your ratings and comments seriously to help improve the experience. And finally, watch for our next quarterly research webinar in May. where the speaker will be discussing the findings from a mixed method study on COVID-19 and resiliency. It's amazing how the data is so similar to these two studies. It's really how registered practical nurses working in long-term care adapt in times of personal, professional, and institutional crisis. So your themes and the themes that are going to be presented in May are just really interwoven. So you're on the right track, we're on the right track, and we just have to continue to try and support those on the front lines, and RPNs being some of the most important human assets. So good night, and thanks for joining us, and have a great evening.
Okay.
Thank you. Good night, everyone.
Thank you all. Good night.